those who are telling us we should scrap SHA?
They should pray very hard that they don't fall sick one day and they find themselves in a situation where they can not foot their bills, and if not them, one of their relatives. Let me give an example. If someone needs dialysis suddenly, and that is 80% of all the people who need dialysis, they find out that they need dialysis one day when they collapse, and they wake up in an ICU, and they are the last to know that their kidneys failed. Why? Because kidney disease is a silent disease. It will work on your body without you knowing. You will feel some changes which you will correct with Panadol and other adjustments, but eventually your kidneys shut up. By the time you wake up in ICU, you will have received probably 4 or 5 dialysis. So you will already be in the red for 50,000 shillings, even before you have been told what is wrong with you. That is how critical it is to have a cover that can take care of you when you're in that situation.
Thank you very much, Mr. Gikonyo. Mr. Gikonyo has told us one more thing. He has told us the best way to get out of, the whole space around dialysis, because dialysis is good because it saves lives, it prolongs somebody's life, but kidney transplant would actually solve that problem in a much more fundamental way. Is that correct, Mr. Gikonyo?
Yes, sir.
So, and he says there are now restrictions on how somebody gets access. It has to be a member of their family. And he has given us suggestions by way of feedback, which is the reason why we are having this conversation anyway. We want to know from citizens, how can we do this better? He has told us that we should expand the pool of access to kidneys to non-members of the family, and possibly create a framework where we can get organs or kidneys from deceased persons in a framework that is acceptable legally and morally. Is that what you're saying?
Yes, sir, but if we had a deceased organ program, we would expand donations to beyond kidneys, because we would now be able to get other organs that are transplantable, and a human body can give up to 8 organs that can be transplanted. So it would be a wider pool where even other conditions can be supported.
Is it something that can be considered? Is it something that, it tells us that there was already a conversation in that direction?
Your Excellency, we are, as a country, we didn't have enough policy and legal framework. But after what happened in Eldoret and the whole story of organ harvesting, the committee which Dr. Wala here, not the president now, but the leader of Kenya Renal Association, was a member among many other experts. That report now is before Parliament, both the Senate and the National Assembly. There was some work we were to do as a ministry, develop the policy, the framework, and the legal instruments, which we are about to finish. Parliament is ready and waiting for us so that we present to them. So that as a country, first we have the framework, the legal, and the policy, which I will bring to Parliament and the Cabinet.
So I think we can then tell John here that what you are suggesting is already under consideration. We must, however, guard ourselves against what we saw in the past, where citizens were duped into organ harvest scheme. Some of them, their organs were taken without them even knowing. and some of them were, conned and things. So we must have a robust policy and legal framework that is already in discussion. And then we can maybe progress and get to the suggestions you're making on how can we save more lives and how can we expand the pool of how a renal patient can access a kidney to save their lives or to share with another citizen. So I think that is a work in progress. The last issue that I picked from my good friend there is they need better participation in the policies that we are implementing. And I think he is just speaking to a constitutional principle. It is no longer a sterile provision of the Constitution that public participation should be part of the engagement of us going forward. And therefore, I think what he's asking for is, as you develop the policies and the legal framework that affects people like him, they must be involved. And I want to commit Bwana Kikonyo, that is going to be the case, and you will you will participate.
Thank you, sir.
There is one more good lady. Sorry, I didn't get your name. Yeah, she has told us. Sharon. Sharon has told us about children living with disability and caregivers who are supporting children living with disability. And she has recommended two things. She has said we need to look at the package that is available to children living with disability, including the caregivers. What is it that we can tell Sharon and people like her who are helping with children living with disability? And she has recommended specifically that early intervention could actually make things a lot easier for both the children and also the mothers. And that these are children who deserve, support. What do we have to tell her? Mercy, do you?
Thank you, Your Excellency. If I'll start with the good news on your instruction yesterday at night, we started work on diapers, and the proposals are underway, and we should be concluding that by the end of October. And Prof. Jaco's team has already started looking at that. On what Sharon has raised, it is another area of progression that we need to work to. A child who has spinal bifida, which is a condition where the spinal cord grows outside of the body, requires care for life. And so it means that this child requires physiotherapy, speech therapy, nutrition therapy, almost every day, if not every other day. So what we need to do and what we are going to do is do the costings of that, determine how many Kenyans would be needing that service, what again the budget impact of that is, and how SHA can finance it. But Your Excellency, there's also one more area where the Council of Governors can support us. Kenya over the years has not invested in cognitive disabilities for children. We do not even have the right specialists in place. We have very few speech therapists, very few autism doctors, very few doctors who deal with those conditions. So there's some work that the ministry together with COG needs to do in training, in building this workforce, and then also in building the facilities that come with this. But from a SHA perspective, we're going to review the package and see what we start with. Do we start with 2 sessions of speech therapy a month? While we know that you require more, it's a progressive journey.
Okay. Sharon, I think we do not have good answers for you. Let me say that. But it is good homework, This is a space that is new. It is a space that maybe was forgotten. But I agree that it is a space that we must begin to, think about, whether it is mental health. It's becoming a very serious challenge. All the other issues that have to do with disability. That is a space that maybe the ministry and us, we may need to explore more and look at what interventions we can come up with so that people like Sharon and others who support people in that space can be attended to. Sharon, you want to say something?
Thank you so much, Mr. President. Okay, I have another one again. We have anticonvulsants. Myself, I take anticonvulsants. I'm epileptic. So these drugs are very expensive. And some of them, we get them at the hospital. Yes, they're being given for free. Unfortunately, some of them are very expensive. We don't get them at the hospital. So can SHA again put us on that kitty? And my question is for my request is also for our governor, Mr. Sakaja. For many counties are doing assessment for children with disability for free. Why is it hard for Nairobi that our kids can't have the assessments can't be done for free? And if it's that difficult, can we also put it on SHA so that we may enable many parents to register their children when it comes to registration for persons with disability? I know he's asking himself which it's the National Council, the card for the National Council for Persons with Disability. Okay. So that it might help us to identify how many parents do we have, how many children do we need to have the diapers, how many children do we need for anticonvulsants, and how many children with disability do we have, how many persons with disabilities do we have. Yeah, thank you so much.
Thank you, Sharon. And I sympathize with Sakaja because he's almost in the same space as myself as to what exactly do we need to do here. Oh, you have something? Okay, Johnson.
Thank you, Excellency. I think it's good to be here, and I know many people are from the city. The first issue on occupational therapy, we provide that in our level 4s and in our level 5s. Occupational therapy, physiotherapy. At Mama Margaret, I know we have, we're registering, we're doing the registrations, even of PWD, the benefit from free diapers, and medicines like phenobarbital. Phenobarbital is available there. We have occupational and basic therapy as well as at MLKH, as well as a serious orthopedic unit over there.
I think she was saying, Johnson, the assessment. He said,
I'm getting to that.
Okay.
Yeah, I'm getting to that. Your Excellency, for occupational therapy, I know for sure it is free at, for assessment, disability assessment, I know for sure it is free at Mama Lucy, Kibaki Hospital. But if it is not free in the other, my CEC is quickly checking, it will be free from tomorrow if it is not. I will direct that it is done. In case it is, that is very easy. And I know they are listening. But I'm just confirming, I know for sure it is free at Mama Lucy. We'll make sure it is free. I don't think you need to be charged for just that assessment, Your Excellency. Thank you.
Thank you very much. Now, there is one thing that is coming out of this, that we may need to expand our, health professionals, scope, to cover new areas. We seem to have gaps in certain professionals. I think somebody mentioned here that there are gaps in some expertise that may be necessary for us to handle situations that confront our healthcare facilities. We need to have the people with that expertise. I don't know whether in this room we have the director of Kenya Medical Training Center. Is he here? Yes. Yes, Daktari, last year we had a conversation. And we had a conversation on, expanding the footprint of your organization. You also brought to my attention that you needed to hire more lecturers so that you can expand the courses that you are offering in our Kenya Medical Training Center. In the context of the conversation we are having, listening to Sharon and the professionals we need in that space, listening to others here, and the feedback we are getting from people, in this year's budget, we have provided money for you to hire an extra 1,200 lecturers and people who will help in your teaching facilities. In this year's budget also, when you did request me, we've also made money available for students at KMTC for Higher Education Loans Board. I think 390 million or so. But I also understand that that money may not be sufficient. And I want to tell the good people, health professionals who are training at our Kenya Medical Training Center, that now, as we improve on the package for tertiary education, we have taken the law to Parliament on tertiary education placement and funding bill that will now cover all students at KMTC to access funding for their training, so that these gaps that exist at the moment, we will settle them. What do you have to say, Daktari, on listening to this conversation? How do we, or how will your organization, with the pool of health professionals that you are training, how will your organization help us and help, citizens who have different conditions, who require different professionals? How do you think we should approach this? And what kind of support do you need from me to be able to provide for beyond what me and you and PS Muthoni here discussed?
Thank you, Your Excellency. My name is Dr. Kelly Olwach, CEO, Kenya Medical Training College. Your Excellency, to start with, KMTC has increased the number of courses from 98 to 126. That is 28.6% increase in the number of courses. Your Excellency, thank you. We are talking about speech therapy. Your Excellency, Kenya Medical Training College now has a diploma program in speech therapy. We also have a higher diploma course in speech and language therapy, and also a higher diploma in audiology. Your Excellency, I'm cognizant of the challenges that children with disability face, one of which is delayed speech. And Your Excellency, the country did not have specialists in this area in the health field. Kenya Medical Training College, in response to those challenges, has now a diploma and a higher diploma for that program. And the demand, Your Excellency, for speech therapy services is exceedingly very high. I want to thank you, Your Excellency, for leading us into that direction. Your Excellency, I want to also thank you and discuss with the nation about HELB financing at Kenya Medical Training College. Your Excellency, in 2022, Kenya Medical Training College had 54,000 students. Currently, Your Excellency, the institution has 89,000 students, 700. Your Excellency, that is 36.7% increment in the number of student population in Kenya Medical Training College. The rise in the number of students in Kenya Medical Training College is in response to the challenges that the country is facing in terms of shortage of health workers. Your Excellency, one of the challenges that we also faced because of COVID-19 was global rise in demand for health workers. Your Excellency, because of the leadership that you've given us, we have had 185% increase in the processing of documents for those who are going out of the country. And we want to increase that to support our youth to get employment out of the country. Your Excellency, on the issues of training and the issues of HELB at Kenya Medical Training College, it has been an on and off challenge. Your Excellency, The first promise we had for consistent help funding of Kenya Medical Training College was in the financial year 2022-2023. Kenya Medical Training College, despite having a growing number of students, did not have a proper way of funding for those students because we exist in the Ministry of Health and not in the Ministry of Education. Your Excellency, in 2012-2023, Kenya Medical Training College received help funding equaling to 641 million. In 2023-2024, Kenya Medical Training College got 605 million. In 2024-2025, we got 511 million for student financing. However, there was a shortage last year where our students did not get any funding. Your Excellency, when I brought this to your attention, you were very quick to take action. The first action you took was to request Treasury to assign resources for Kenya Medical Training College. As a result of that, we have 392 million as a stopgap measure to support our students through training. We realize that the number of applicants for help is so high compared to this amount of money. Annually, we will require 700 million for new students and 500 million for continuing students. And so, Your Excellency, you gave a directive through a presidential directive dated 6th May 2026, requiring students of Kenya Medical Training College to get special funding through help to support the high number of students who are not getting. Your Excellency, this year's budget has 392 million, and we are also following with the support of my Principal Secretary to get students of Kenya Medical Training College be permanently put under help to end the perennial challenges that our students face. Your Excellency, I submit. Thank you so much.
Thank you very much. The good news, Daktari, is that we are changing help and combining it with KICC into the tertiary education, placement, and funding in the bill, so that we combine the placement and the funding, so that for every student we place in a college or a university, we will have figured out the funding for that student. Because the development of our human capital is central to our development as a country. It is the single most important asset that we have. And I just want to give you assurance, and to the students in the Kenya Medical Training College, that this on and off trial and error is going to be a thing of the past. The same way we are funding all our students in TVETs and in universities, KMTC students will now permanently be part of that arrangement. Mercy?
Yes, Mr. President, I know time is far gone. I want to seek your indulgence. As you can see, many notes have been coming my way. My phone is ringing and many messages from the people in the room who still want to speak. We have a team from Moyale. We have persons living with HIV, persons with disability, on local manufacturing, local manufacturers. So if you allow, we can quickly hear from them, and then we wrap it up after that. All right. Let's go to Moyale first.
Thank you, Mr. President. Indulge me because I'm having cold. Yeah, so my name is Getu Samuel Sake. I come from Moyale, Marsabit County. I'm here with a team on this end, and also I'm here together with two elders to tell a story. Mr. President, we are really thankful to you and to your government for organizing this summit. Beyond 2030, we as a team from Moyale, we have a story to tell. There's so many beautiful stories being told here, but we as a team from Moyale as well, we have come to tell a story that is unique to many of you. So if you will indulge me with your permission, I have two elders here. Though language is an issue, I will request maybe a translation that will tell a story, and later on I'll make a submission on the same. With your permission, we have two elders here. On the far end, Mr. Gabayo Osha, and also Pastor Mare. With your permission, let me pass the mic so that they can tell us the story, after which I'll make the submission. Thank you.
I'm sure they can speak Kiswahili. Wanaweza kuongea Kiswahili, hakuna problem. Unaweza ongea Kiswahili?
Borana.
Ama iko problem?
Yeah.
I hope nitamsaidia. Thank you.
Makanki Gabayo Osha dani.
Kwa majina naitwa Gabayo Osha.
Moyale dufe.
Mimi ni mkaaji wa Moyale.
Uji yokan kanisa kesat uji wa aujada.
Nami ni mzee wa kanisa ambaye tunamtumikia Mungu pale.
Kabajama wanenogaran dofnefi.
Mheshimiwa Rais, kile imetuleta hapa
shani Moyale namedon sha infayadama.
Watu wengi wanatumia SHA.
Amo challenge amna.
Lakini tuko na changamoto.
Community ni oja SHA tumitu mgonjwa didik agana insabaibiti.
Jamii wako pale wanapotumia SHA wanasaidika kwa magonjwa madogo madogo.
Amo maro economic areas nami oriti fata.
Kwa uchumi na watu wa huko ni wachungaji wengi wao.
Yo gariboni dufe wanarka amanam durafuda.
Saa zingine kiangazi inapokuja inawapokonya kenye wako nacho.
Lukubu gurda okani yo fayada bani.
Wanapogonjeka magonjwa makubwa kama kansa na kadhalika.
Achiti yo stroke fargatan, yo accident fargatan, yo lafe facabd.
Wapo wanapopata na stroke na wanapopata ajali na kufunjika mfupa.
Rifaro gar Meru fa korani.
Wanaandikiwa rifaro kupidane Meru na sehemu zingine za nchi.
Meru gar kilomita dibishani oli.
Na Meru iko mbali na sisi zaidi ya kilomita 500.
Adumdemu nami karadwa.
Tukiwa tunamsafirisha saa zingine watu wanaaga.
Time inachidakabani finami kuni dibu argate karalu buda.
Kwa sasa kwa vile hawatanifikisha pale haraka mtu anafariki.
Nami garillen serikal dibi fade mujariba.
Kwa ajili ya ubali watu wengine wanavuka pande ya Ethiopia wanaenda huko kusaidika.
Akdan samarro full area suno kamfula suni hospitali akdan sa dibgu gurda kan karkarun dandenefi.
Kwa vile hatuna hospitali ambayo ina deal na mgonjwa huyo.
Achi gar Meru dufuitin transport mbeso guddo.
Kutoka Moyale paka Meru kukuja ni transport ni mingi.
No kanisa yo kan committee lewalini.
Pamoja na jamii na watu wa kanisa.
Wani afurat Allahni takamin gumi fayad abdikan amna ya jedan yani.
Sikufanya tu jambo la kiroho lakini tukakaa chini tukafikiria tutaweza saidia jamii wetu namna gani.
Akamini diyotoni kunudi hati anna nami karkarsar gata.
Ndio tukafikiria kwa jinsi gani ndo sasa tuwe na hiyo facility ambapo watu wanapata msaada.
Committee wale walagene Moyale community hospital wanjaran obja kasi objanne.
Tukawa na nia na ndoto ya kujenga hospitali ya jamii kule Moyale.
Akanami karkarsar gate ujintun tashayalle akitan saksin demtu.
Ili watu wapate msaada na mambo ya SHA pia ifanye pale vizuri.
Tamisho nani tidaru?
Ya misho.
Debi kun ganadera demu jira area sunit.
Kwa hiyo sehemu sasa hiyo shida inaendelea kwa muda mrefu.
Nairobi odufan distanti mfago.
Wanapokuja Nairobi ni mbali.
Meru mfago.
Na Meru iko mbali.
Yo wiikum dabarte wiikilam ka dabarte jaarsi tokko akka malee fayyaa dhabe.
Si mbali tu wiki mbili iliyopita kuna mzee alipata shida.
Masaa tokko lam keessatti haraka dhaqqabaa jedhan hospitaal.
Walipompeleka hospitali na wakasema mfikishe tu haraka iwezekanavyo within 2 ama 1 hour.
Agmeeru dandani 1 hour 2 hour dhaqqabuu dandanu.
Huyo mtu sasa huwezi mtu kumfikisha huyo mtu yani kwa masaa mawili ama masaa moja afike Meru.
Amma warri sun namni hedduun adoo waakkadhatu jaarsi sun diqqum ka waaqiitti dhaqqabee hospitaalaan bahe.
Sasa tukiwa tunaomba sasa Mungu akamsaidia huyo mzee akafika hospitali Meru.
Namni tokko accident argate yoo mataafa dhiba argate hojjaa sun qarqaarsa argachuun rakkoo.
Kama mtu mmoja anapopata ajali apate shida kichwa, kupata msaada ni shida.
Tanafi kabajama.
Kwa hivyo Mheshimiwa Rais,
nullen objutan qabna,
nasi tuko na hiyo maono ya kujenga hospitali ya jamii kule eneo la Moyale.
Akati barcuma guddoo fudhattee nullen xixiqqaa fudhannu asante.
Nami pia tunakualika ili uweze ukaungana nasi tuendeleze shughuli hiyo.
Asante sana.
Haya, ngoja bwana Gabayo. Akam?
Yes, sir.
Unaelewa Kiborana?
That's sir.
Yoya. Mimi nakuuliza kwa sababu sasa umesema mnataka kujenga I understand ile unaniuliza ni kwamba tuwe na hospitali Moyale ambayo inaweza kushughulika na haya magonjwa umesema yanayozidi dispensary ama health center. Na mimi nataka ujue hivi, unajua Sololo, pale Sololo sasa tuko na hospitali level 4 na nilitumana equipment kupitia kwa wanajeshi wetu, tulijenga hiyo pamoja na governor wenu. Sasa kuna equipment pale Sololo. What I think my good friend is saying there is the challenge of us having facilities that have capacity in level 4 to attend to some of the situations that now they are going to hospital in Meru. So I think we understand what you're saying, and thank you for the initiative that you have started to maybe build a facility for yourself. But I think meanwhile, we can find a mechanism working with the county government to equip some of the facilities under our national equipment program. We can equip some of your facilities so that they can serve the people of your county. Please explain to him. Thank you very much. I think you can explain to him what I have said in the language that he understands.
Allow me, Mr. President, to pick 2 more.
Mr. President,
sorry.
Let me just make a submission in a minute.
Yes.
Yeah, thank you so much for your indulgence again. As you have clearly articulated, the challenge here is the distance. And beside distance, this is not interdiction to Moyale General Hospital and Marsabit Referral Hospital. But if you look around even the entire Kenya, those hospitals that are serving Kenyans properly and people are getting service from there are mostly mission hospitals. And within our region, one that we have is Sololo Mission Hospital. That hospital has saved many lives. And the other closest, which is nearly 500 kilometers away, is Kirua Mission Hospital in Meru. And now looking around the issues that we are seeing, why are we here as a church? It's because if most of the time we go out on a medical camp, and the most experience, the challenge that we see and witness every now and then is that there is that recurrent issue, especially around Kargi region in Chalbi area, Kargi to Sololo to Moyale. There are cases over decade, cases of cancers, especially throat cancer and stomach cancer. One good case example is my Shosho. My Shosho passed away back in around 15 years ago. She passed on with cancer, and many other cancer cases are there. Just imagine the distance between Moyale to Nairobi, or the distance from Moyale to Meru, that is a life. So the challenge here is the challenge of diagnosis, after which there's issue of treatment, and look at the distance. All this issue is really troubling our people. That's why we are saying, as a government, kindly we request that if these facilities, as you have clearly put, if it can be brought closer to us, probably Marsabit or Moyale, it will be helpful. So in that endeavor, we as together with other stakeholders, especially faith-based organizations, we have been keeping in touch, we have been talking, and also the communities around and other stakeholders. We try to reason, and we said we will put up a hospital that we seek mobilization from different areas. As a result of this church, they were able to provide 8-acre piece of land for such a mission hospital to be built. And so as a result, they have consulted different organizations, and already plan is underway, and they have already started construction. Therefore, here, as a team here today, as we address the plight and issues facing the northern region, because most of the time, let me say this, Marsabit and Isiolo, most of the time they are being confused with northeastern region, that is Garissa, Mandera, and Wajir. Most often, we get lost under there. But we, those are the northeastern, but the actual northern, those who are there, we face these challenges. The challenge, the Moyale General Hospital, it serves the border.
Excuse me, if you allow me just to interject, Mr. President, I'm being told there is a level 5 hospital in Marsabit that is currently undergoing construction by, this is from Dr. Wilson Arwasa. I don't know if he's in the room. Maybe that can...
I think Duale is here.
Duale.
But,
Okay.
but I think the point he's making is that we should make more facilities have equipment that can help in the treatment of cancer and all the other. And I think this is a matter that had already been spoken to by the chair of the council earlier, that we need to assist counties to be able to have the requisite facilities, especially on matters to do with cancer, because it's a real disaster in many communities. And in the past, people had to travel, to Nairobi and to all the other places. With now the elevation of some of the facilities to level 5, we should be able to make those facilities available, in those hospitals, so that we can deal with the case of Moyale.
As I see it, kindly allow me to present this document. One, here we have a concept paper on our project, as well as
Please,
an invitation
you can pass it on to
for
the gentleman
you
there.
to attend in our fundraiser. Thank you so much for your time.
Thank you.
And God bless you.
Thank you.
Thank you. Thank you. Thank you for that. Thank you, Mr. President. Allow me to bring in 2 more based on our conversations yesterday night. We discussed a lot about the equipment, services, and local manufacturing, availability of medicines. And I'm told we have a local manufacturer of, I think, medicines that would want to speak. And then we had a conversation about registering Kenyans to SHA. I think the number is, once a country is at 85%, then you are well on the way to UHC. And Mombasa County, Governor Abdul Swamad, as that yesterday, was at 84%. And the co-chair of the UHC 2030 would want to comment on that. So allow me to pick on those 2, on the local manufacturing. Behind me. Okay. Who? Him. All right. Your name just in under 1 minute, please.
Thank you very much. Your Excellency, the President, all the dignitaries, my name is Dr. David Maina. I'm a pharmacist in the field of local manufacturing, and I'm here on behalf of my fellow colleagues who are manufacturers. We want, first of all, on behalf of the local manufacturers, to greatly thank you for this audience, and for your commitment towards universal health coverage. We are very grateful. We've actually been looking for such an audience for a long time, and this is the right time. Your Excellency, we have about 40 manufacturers, local manufacturers in Kenya. The 40 manufacturers produce medicines and take care of about 30% of the local consumption. Your Excellency, that's very key, because what that means is that the other 70% is not made locally. That means it is imported. Let me also emphasize that the percentage is not in terms of the number of packets of medicine, it's a value. So if the local manufacturers are doing 30%, the 70% imported is high value. And if we did it locally, it could cost us maybe 30% or 40%. Having said that, we also, as a manufacturers, we employ about 1,500 people, about 15,000 people directly, and many more in the value chain. So local manufacturing is a very, very important docket. When I heard many people talking, Your Excellency, they were all referring to medicines, dawa. In fact, some said, unatibiwa, unaambiwa hakuna dawa. At the end of every service delivery, of health service delivery, is a product. That is the dawa. And that's where we are placed to ensure that we provide those medicines to the patients so that the whole ecosystem of treatment can be complete. When COVID struck 6 years ago, there was a general crisis in supply chain of pharmaceutical products. In fact, Kenya could not even import a simple sanitizer. Even masks were being imported, that used to be imported, we had a shortage. So I'm saying that because our space, and why this is very important, has two aspects or very objectives. One is to play our role in universal health coverage in terms of supply medicines, quality, affordable medicines. The other very important one is actually disaster preparedness. If another COVID came, that would be a disaster. Would Kenya be prepared? How prepared are we if we are importing 70% of our medicines? It's a big security threat to this country and all the countries in the region. With that, let me acknowledge your support, Your Excellency. 2024, about 2 years ago, we were here at KICC, and you gave a commitment that Kenya need to carry from 30% to at least 50% supply of local produced products by, I think, 2026, end of this year. With that, I'm happy that we have gotten very good support. Let me give credit. We have a very good Ministry of Health that is very supportive, extremely supportive. There's even a Department of HPT, Health Products and Technologies, at MOH that is supportive. In fact, recently, they mined all the data and have a local manufacturing, pharmaceutical manufacturing strategy that was recently. That is very welcome. We also acknowledge, Your Excellency, that you are actually the champion of pharmaceutical manufacturing in the region, the IGAD region. And we are proud that our president is actually the champion. We have good support. However, we have some challenges that we are facing that are preventing that achievement.
Sorry to cut you. If you could just make that brief and maybe do it in a minute.
Yes. I'm going to be very brief. We have some 4 challenges I'll highlight that are making that achievement scaling to 50% become a bit difficult. Why this is important? Because despite the support from MOH, we feel that the challenges cross across the ministries. And it's only probably from your level that can be sorted out. I'll be very brief with that. Number one is the cost and the competitiveness of our local products. We have a situation whereby our inputs are very expensive. Because of compliance with quality, and especially now Kenya is undergoing maturity level 3, ML3, our factories are very expensive to run. High electricity bill, all the inputs very expensive. In addition, we have taxation that is not pro-local manufacturing. Especially, we have excess duty on packaging material. Recently, there is VAT added on some raw material. I know that's being sorted out. Why that is, let me add that despite that, we have import duty that is exempted. That's very good. We don't pay import duty. We don't pay IDF fees. We don't pay levy. That's very welcome. But the few things that we pay, like excess duty on packaging material, it's making our products very expensive. We have been engaging MOH for the last 3 years. And we feel that there is a disconnect between MOH and Treasury. Because Treasury on one side says that they need to protect local printers, local paper manufacturers. So they put excess duty on imported packaging material at the expense of pharmaceutical manufacturers. But we can sort out by actually ring-fencing the local manufacturers only. That is an example that imported glass bottles have excise duty into bracket apart from local pharmaceutical manufacturers. That can be done for packaging material. But that has all been done for the last 3 years, and we kindly request if that can just simply be done, we'll be more competitive. The costing part of it also, we are competing with imports, the 70%, majorly from Asian countries. Those imports from their source have been exempted all the duties, and in addition, they get export subsidies where they are bringing to Kenya. You find such that you're competing with a product that is all exempted, well covered by the government, and you're competing with it here. That is us the competitiveness that we are asking for. Number two challenge, because I want to be brief, is about regulatory challenges. Among the 40 manufacturers that I mentioned earlier, inspection by Farmers and Processors Board last year, and it's a good inspection because it is towards maturity level 3, which we fully support. We are in full support of level 3. We think it's a good thing. But despite that, that inspections made 12 companies be suspended their licenses. That means from the 40, you hive over about 1/3. What that means in short is that if you are doing 30% supply to Kenya, you are removing 1/3 of it. You are left with 20%. So we are likely to be in a worse position now, although it's temporarily because of the inspection, than we are then. The other part of the regulatory challenges is that those countries we are competing with, where they are registering a product, they take 3 months to 6 months. In Kenya, we take about 12 months at best to 36 months. That means if we want to have more products, 50% achievement, we have to register more products. There needs to be a fast-tracking method to have those products in the market. Your Excellency, you mentioned, and rightly so, that you negotiated reduction of price by one foreign company from a certain figure to 1/3. The question is, they were making profit when they were at 100%, they are still making at 30%. That's the kind of level we are losing by importing. If those resources in foreign exchange can be put in local manufacturing towards the taxation and other cost remedies and support for registration, we will actually achieve that faster. Number 3, and I'll be very brief, is about capital. Okay? We have a situation whereby it is very capital intensive to run pharmaceutical companies. Just the way we have our funds for agriculture and other departments. If we could have a pharmaceutical industrial fund, and we don't want goodies, we don't want anything for free, just easily borrowing and payment, it will help a lot. Because banks perceive pharmaceutical manufacturing to be a specialized field and therefore very risky. They are not willing to maybe buy a machine that is not universally used by other people. Finally, we have KEMSA, which is the biggest purchaser of our goods. KEMSA and county governments. KEMSA and county governments have a policy of the lowest price. That means the initial charge I mentioned about the competitiveness applies when you're tendering for KEMSA. You find that the imports, we can't compete with them. Therefore, despite maybe a 15% allowance, is not enough to attract many local manufacturers to sell more. And even after selling, and this is where maybe the KEMSA needs to hear, takes about 6 months to 1 year to pay. If that can be sorted out, we'll scale up to more produce manufactured. We are ready to support you, Mr. President. If we can have that support, we can actually make quality, affordable medicines, not just for our country, but even to export to our region. Thank you very much.
Very well put, Mr. Maina. Yeah, very well put. I have a couple of questions for some. I think we need to answer this question. I mean, we have transitioned. We were saying initially financing is critical. And then we said human resource is critical. Now we have gone to, without medicine, there is no healthcare, according to Maina. So everything in the chain looks like it is critical. Agreed that we're producing only 30%. That was in 2024, we had a conversation. And my instructions to KEMSA then was we give priority to locally manufactured products. I want to understand first whether, and I had even specific examples. I had, for example, one facility in Kilifi, Revital, and I think they are here. And Revital was manufacturing a lot of stuff in Kenya and could not sell to Kenya, but they were selling to other countries. And it was because of a conundrum at the KEMSA. And I said that should be undone. I don't know whether the CEO of KEMSA is here. Yes. Can you explain to us, I know there was another CEO, what is how has things changed in terms of your purchases? We insisted that local manufacturers should be given priority. Specifically, are you now buying from Revital and they are here? If you say something that is not correct, they will say something different. Just tell us.
Thank you, Your Excellency. Yes, so local empowerment is very important, including manufacture of pharmaceutical products. We are keeping a tap on that. Revital can attest that nowadays they don't complain, they don't write letters. We do a lot of procurement from them. But in general, under your direction, we got instructions in order that we should do more than 40%. I can attest here that our procurement from local manufacturers is 52%. And in fact, from international manufacturers through our local suppliers, when you add those two, over 70% we buy locally. So the preference in procurement works when there is an international competition. We give, according to the Public Procurement and Asset Disposal Act, we give 15% preference to the local manufacturing. And by local manufacturing, 100% fully owned by Kenyans, or more than 50% owned by Kenyans, they enjoy a 15% discount. The only trouble comes in, I think Dr. there has talked a lot about other issues outside us, which affect their costing. So as a government, maybe that can be looked at, but yes, we do, and
Thank you very much. Thank you very much, Wako. Revital. Yes, please pick the mic.
Mr. President, thank you. I represent Revital here. I would like to attest to what Dr. said. Yes, we have been getting local tenders and we are able to get that preference. However, mobilization of funds after the supplies is something what we are still chasing on. So one tick box checked, but the second one is still in the progress. And just to add to what my colleague said, just like our neighbors, they come up with policies like BUBU, like Buy Uganda, Build Uganda, wherein they are giving preferences to the local manufacturers by increasing some taxes for the imported medicines and products. We are also looking for support from you on that.
We will go there.
Yes.
I will go there shortly.
Sure.
So I just wanted to confirm that we have moved our locally manufactured products in KEMSA from what it was to now you tell me 52% of your purchases are from local manufacturers.
Yes, Your Excellency. I only have one problem with the manufacturers, which I'll take the opportunity. When we strictly label the advertisement to attract only local manufacturers, then they tend to hike the price because they know the international bidders are not in. So I plead with them, when they see it's restricted for local manufacturers, we are a commercial entity. So if they don't give us room for markup, we'll not be able to pay salaries.
Minor, there is some homework for you and your team there. You know, we do not want you to shortchange us. You know, the moment we lock out your competitors who are international, you must not do a cartel business here and hike prices, you know, really. Because we really must be honest with ourselves, because this is public money that we are using, and we want to get value for money. So I think the issue raised by the CEO of KEMSA is an issue that you must address so that we can support local industry and still get value for money for the Kenyan people. We do not want to say, because it's a local manufacturer, then we pay more than, you know, is reasonable for us. That is one issue. But my instructions to KEMSA was that progressively, we must get value for money, but we must support local manufacturers. You have raised a couple of issues. The first issue is we will do affirmative action. I want to confirm to you, we will do affirmative action on buying from local manufacturers. That is number one. And I want to encourage counties, when they too are buying, let us try and see how we can support local manufacturers. You have raised some issues on taxation. We did what Maina said. We removed some taxes, IDF, all the other taxes. You are telling us to go further and, you know, ring fence, because, you know, we do not want a situation where we are promoting local manufacture in one space and we are undermining another space. When we put duty on imported paper, it was because we also wanted to support local paper manufacturers. So we must also balance between manufacturers of local paper and the pharmaceutical industry who may want to use paper that is not locally manufactured. And what we should be able to do, and I think Duale, your colleague in industry, Lee Kinyanjui, and Badia Treasury, you should be able to sit down and encourage local paper manufacturers to manufacture the paper that these good people can use in the pharmaceutical space, so that we have we sort out both sides. And now we will be willing to have a conversation, Maina and your team, on how we can bridge the gap between local paper manufacturers and yourselves, and whether it is absolutely necessary to ring fence paper for packaging for pharmaceutical companies in the manner in which you have suggested. Number three is we are trying to transition the country to ML3. And, you know, we have to meet certain conditions. If some of our local manufacturers don't meet those conditions, you know, we will undermine the position of the country if we don't meet certain international conditions. So unfortunately, we will have to, you know, to ask some of your local manufacturing entities to up their game, honestly. And the Duale and the PPB people, and Duale, do you want to say something?
Excellency, I know Maina very well. And I had a session with the Kenya Pharmaceutical Association more than 5 times. Today, under your leadership, we have done the reforms that has never happened in our country under BPP. And I want to share this with you. Number one you have answered. Maina is telling us to protect local manufacturing. But the same Maina wants to go and import packaging from outside, and then we remove duty. All that we're telling Maina is there are competent companies in our country who do the printing of packaging and who gets that favor from the National Treasury. To Your Excellency, as we transit to ML3, which you have directed, I mean, Kenya is big, it has a big pharmaceutical base for the country and for the region. Kenya is about to attain ML3 by October this year. For us to do that, we have stopped all parallel importation. Because parallel importation was where a lot of fake and counterfeit medicine used to enter our country. In fact, 2,500 products have been removed from the system of Pharmacy and Poison Board to make sure that we, number one, for the safety of our citizens and the dignity of our patients, we must stop counterfeit and fake drugs. So 2,500, there are many people who are complaining. Number 3, Your Excellency, and I think Maina must be be aware, is that for you to establish a pharmaceutical manufacturing firm in our country, all the equipment and machineries are of free duty. They have a huge, no any other country in our region gets that kind of tax incentives. All they need to do is to get a letter from the Ministry of Health to the Minister for Finance, and the Minister for Finance will write to KRA, and they get all the incentives. And that is what we did in the last 4 years. Today, there are more than 12 new manufacturing pharmaceutical companies now. 2, when you created the incentives that the local manufacturing preference be done by KEMSA, a lot of now Kenyan investors, working maybe with other foreign investors, are now establishing their farms in Kenya. So the reform that we are undertaking, I know the one that he wants me to talk to the Minister for Trade, Minister for Finance. We are in engagement. But again, we must balance. The kind of incentives our pharmaceutical industry is gaining, Your Excellency, is so phenomenal that the element of the packaging, which is very important, all that the National Treasury is saying is that we have given that incentives, that tax incentive to locals, not that you bring it from outside. And I can confirm that Revital, under your direction, and all other companies, what the CEO is saying is true. What they used to do before is they used to mix things, and you're aware of that. Now they're doing specific procurement for specific items. So Revital, unlike before, now they sell to. On the issue of the payment, I think that is now a commercial interest, 90 days, 45 days, 60 days. Social authority under their contract is 90 days. So I think that's something we can discuss. But Your Excellency, the reforms that you asked under PPP is on course, and is for the benefit of the country.
Thank you very much. I think this is a fair conversation. Maina, you agree. It's a fair conversation. I think you have asks. They must be, balanced with other, but I think if there is one space that I am very confident about, especially after the meeting I had with the manufacturing community in Kenya, pharmaceutical manufacturing fraternity in Kenya, we have provided sufficient incentives to make sure that those who want to set up manufacturing capacity in manufacturing facilities in our country do so. We have even extended, just for your knowledge, Maina, the special economic zone in Thika. We have said that special economic zone should be made available for manufacturers who want to benefit from incentives in a special economic zone space, long-term investments and all the other things. And we have already provided the first phase of infrastructure in Thika for that space. However, I think we still need to have a conversation about us being able to meet our financial obligation to these good people so that we don't undermine their business. And I thought we provided a facility to KEMSA of 10 billion shillings so that you can be able to pay your suppliers, when it is due, as you wait for the counties and all the other people to pay you. How about, what are you doing? Isn't that some place where you can see how to manage the financial outlay of these manufacturers, especially the local ones who require support?
Thank you, Your Excellency. Yes, absolutely right. I think financial sustainability for KEMSA is something we've been working on under your leadership and the Cabinet Secretary. I really want to thank you for taking it head on. So we have a lot of issues. I know governors are here, the chairman is here. The payment cycle, picking orders and paying for it takes a long time, thereby also affecting our own suppliers. So that facility, yes, I can confirm, it is on. We're just waiting to sign an agreement between the counties, ourselves and SHA, so that we have an automated system to go the full 10 billion capacity. As at now, Your Excellency, I can confirm the national referral hospitals, just to give example of what financial sustainability can do, have already signed under the leadership of the Cabinet Secretary. We have signed with the 7 national referral hospitals an inter-parties agreement. Now that has allowed us to get the facility up to 1.5 billion, and that we have already started engaging the suppliers on that. Then when we sign with the COG, chairman is here, and we're working very, very closely with the chair of Health Committee. I even flew to Mombasa to discuss that with him, and I think the future looks very luminous under your leadership. Thank you very much, sir.
Thank you very much. I would really want to persuade my good friends, the governors. I think it is good for all of us. I mean, the principle, and I think we can have this of this stage. The principle is for us to have a complete cycle, that instead of a check-off system, kind of, with SHA on the drugs bit. And I think that's a conversation we can have that will improve the financial ability of KEMSA to procure drugs, and it will also help our manufacturers to be paid on time. I think if we can do that, it would really be very helpful. Yeah, Chair, would you want to say something?
It will be good to have an age data of all the counties to see where they are, because as disbursement flow from Treasury improves, that should also, help them pay faster. But we're also willing to take up that conversation. We have had that conversation of some arrangement which is death discounting in a sense, or whatever arrangement that KCB is willing to take up to help counties pay much faster. Our Chair of Health is here. It's a conversation we're willing to have. But also, if there's just some chronic, late payers, it's a conversation we'll also be willing to have with you. Some of us always only have the last order payable. And whenever we get our money, we prioritize KEMSA. So let's see if there's any problem of age debtors, and then we can have that conversation. As for the KCB, it has to be county by county, but I can get an in-principle approval for, from the perspective of COG. Thank you.
Chair, do you want to say something brief? Very brief. I don't know, we have run out of time. I think my good sister there will run into trouble.
Your Excellency, it's true. I did meet with Dr. Wako, and I did present to the full council the various options. One of the things, Your Excellency, that I think if we finalize, and we can even be able to finalize this on Monday, either at IBEC or something, there is a possibility, Your Excellency, by coincidence, the amount of money that counties have to be paid, and verified amounts, is about 5 billion by the former NHIF, which actually is another example to show that NHIF was not working, because 5 billion was actually due to be paid to counties. There's money that Treasury has already dispersed actually to SHA that was meant to be to pay for NHIF. The agreement that we are proposing is, instead of giving us that money, we do a debt swap. And an example is a county like Mombasa that has money to be paid but does not necessarily have money to pay to KEMSA. We'll do a drawdown mechanism. Same thing with Nairobi. The difference from the amount of money that Nairobi has to be paid versus what it is that they have to pay is almost 700 million. If it is acceptable, Your Excellency, KEMSA gets an immediate financial injection of 5 billion shillings. 5 billion shillings injection of money. And the other one now is so that we do not have this problem back and forth, and we do not sit here after 5 years saying that KEMSA has to be paid and we're in the same dark hole again. We were proposing something that the counties can be able to give some form of a guarantee. I know there was a proposal of deduction at source by SHA, and we came up with another proposal because, upon discussing with the CEO of KEMSA, it is something that excites him even more, because a facility, let me not get into the very, very much nitty-gritties, Your Excellency. Those are for behind the tent discussions that we will have, but we have the goodwill to be able to finalize this.
Thank you very much. Are you trying to use KEMSA to collect your debt in some way?
Not at all, Your Excellency. We all we are saying is that we have a solution to be able to, first of all, give a direct injection of 5 billion to KEMSA. And with that in mind, bearing in mind that counties like Mombasa and many others that actually do not have to pay KEMSA, but we have to be paid, we are proposing that don't even pay us. Give that money to KEMSA and we'll do a drawdown mechanism.
Okay. Understood.
Yeah.
Understood, Chair. I think the beauty of this conversation is that every matter that has been raised here, there is already an active conversation going on. There is an active engagement, either with the ministry or with the county government or with another stakeholder, giving us the right impression that we are, to a great extent, on top of the ball. We know where the issues are. Some of them are being sorted out. We need to accelerate some of them, and we need to do what we have to do to smoothen the delivery of health journey in our country. Mercy.
Thank you, Mr. President. Allow me to just welcome one more comment, because we are looking at health beyond 2030, and the co-chair of the UHC 2030, Dr. Gidinji is here, and he had a comment about We are at 60% registration, 25% more for Kenya to be well at the journey of UHC. After him, you can give your closing remarks and close the summit and this particular town hall. Thank you.
Yes, Your Excellency, thank you very much. I have been seated here yesterday for about 5 hours, today for 5 hours. I feel for you. I don't know how you're feeling because you're the man in the center. And that's not easy. I travel around the world, number of works across Africa. This kind of engagement at presidential level on health is very unique. We don't have it. So thank you very much. Thank you. Again, we don't have a lot to say because we are, sisi ni mafundi huko ndani, we are working with your team here as AMREF very closely. So we are listening as well to just know what improvement is needed. But let me just make a few comments. Number one is that it is without doubt that we congratulate your government's very expansive reform for the health reforms that have been done. We don't often see such extensive reforms. We see one act after another, you know, small, but this government has taken the bull by the horns. And those reforms are not seen anywhere. I've not seen them anywhere in any other country in Africa, honestly. But we have worked with the other countries on one-on-one, but this is really expansive. Now, I want to believe that this conversation, as you said earlier yourself, is not about the next election. It's about the next generation. And because this conversation is about the next generation, then we need to think about this conversation beyond the Social Health Authority. We need to think about it that, for me, when I think about it, I reflect on the fact that there must be a reason why you did not call it root or care. You call it Social Health Authority. Because you saw it beyond, you saw it as something for 2060. Just like we've had NHIA for 58 years, we see this as the thing that's going to hold us together for the next number of years and decades that come. In which case then, I tend to think that we should discuss it honestly. And we should actually, as Kenyans, and I'm really grateful that I've had a lot of conversation. By the way, I chair the board of management for Mbagathi, appointed by Governor Sakaja. So Shikuku, you pointed at me a bit, so I was a bit shy, but I will see you behind the tent, Taonana, over the X-ray. But this conversation needs to be very honest, and I think that's what you're inviting us to do. We need to be honest that this is not President Ruto's scheme. This is actually something owned by Kenyans. And therefore, if it's owned by Kenyans, then Kenyans must be honest to engage on it and say, this is how we must improve it, because this is what we have, and this is what we are going to have for the next, you know, so many years and decades and decades. And therefore, all those conversations that, and you have a team here that is completely able to solve those challenges that are being raised. So I don't want to make that the subject of the conversation. We know, of course, there are civil society members here who support the government. Is there anyone here from civil society? Just raise up your hand so that His Excellency can see how many we are. Civil society, that's the civil society group, Your Excellency, that is spending the days here with you. And we support the government, the county governments, the Ministry of Health, to ensure delivery of the government's projects that you have. Now, the key issue that we see here is that there is a danger. Health financing is actually very emotive, extremely emotive. And I know through the reforms you've had, it's been a very emotive discussion. But it kind of tends to bury the conversations around wellness. It tends to make them invisible because it's so emotive and tangible that you're talking about how much to finance. But the bigger conversation, as the Kenya Health Summit says, is about health. And I think that beyond just talking about health care and how to finance it, which is valid and what everyone else is talking about here, we, with your leadership, need to have a conversation about building health and wellness. And that, of course, starts with SHA, but is beyond SHA. And one of the issues that we see within SHA, and then I can go beyond SHA, is how we can have conversations around legislating and ensuring we optimize level 1 of the health system, community health level 1. And to optimize that, we already have the work you've done, the community health promoters. I can tell you that I've spent my 11 years at AMREF negotiating for governments to actually invest in community health workers at multiple levels, international, regional, and national. So for us to see that realized and have 107,000 that are receiving stipends, that one deserves a congratulations. So thank you very, very much. And that starting at that level, then we ask ourselves, how do we actually optimize this investment entirely to build health? Health means that we identify diseases early, but we also build lifestyle change within the communities using the level 1 so that we avoid the dialysis, so that we avoid the ICU care. Because I can tell you, and I know you know these numbers, that Kenya, at best recovery at 15%, will not get more than $100 of public financing per person per year. Not more than 10,000. That already what we are doing is very, very good ahead of other countries. Well, we haven't achieved 15%, but we can see we are moving towards there. But even if you reach 15%, you will not have covered the amount of money needed to provide health care, not health care to all 56 million Kenyans. Whereas developed countries are spending $4,000, $10,000 per year. We are spending 50. So, and we can't change it. It's the nature of our economy. We can change it constructively as you're doing with taxation, more this and that pulling. But at the end of the day, we must realize we cannot get ourselves out of health care with money. So we have to discuss how to build a healthy population so that we avoid the future costs that SHA has to pay. And for that, we need to think about the community level. We need to ensure there is a policy framework for them to ensure they can actually do the thing that they do in other countries. Integrated community case management, looking at pneumonia, malaria, and all these things. That requires a conversation with the Ministry of Health and all the policy workers. Secondly, the commodities that they use. They need to find a pathway within policy so that they are not a second thought. Like you say, we need now to refill the kits. We need to work with the counties to ensure that they are within the procurement and the Kenya Essential Medicines lists. And that conversation can be had. Finally, it is to enable the primary care networks. They are really critical to your legislative agenda, but they have not been fully operationalized. I think we have worked with the Ministry of Health to develop a primary health care regulations that should help operationalize the primary care network. Because when that's operationalized, then you have a better referral system, and then we have a much better conversation on health. Finally, I need to bring the issue of wellness. That wellness is beyond health care. It's health. And one of the issues I would like to put on your table, Your Excellency, with your permission, is the issues around food regulation. The reasons that you see hypertension, diabetes rising, we see increasing demand on dialysis, is because we have actually left the food environment unregulated. We have people consuming sugars that are unregulated. We have people consuming industrial trans fats that WHO has put a limit on. We have advertising of sugar to children. In the supermarket, the sugar products are right at the counter. The people selling them to us don't allow that in their own countries. So my urge to you, Excellency, is to drive an agenda to reduce the burden of disease in this country by actually starting to talk about food regulation as a public health investment. I think if we can do that, the cost of SHA in future will reduce, and we'll have achieved wellness for the country for the next generation, not for the next election. Thank you, Your Excellency. Thank you.
Thank you. Thank you very much. Your Excellency, you can give your closing remarks.
I think that is a wonderful place. You know, that's a wonderful place to end this conversation and to end this summit on health. We have had a wonderful engagement. I have really benefited from this engagement from yesterday and, of course, in this particular setting. I want to thank all the people who have participated. We have our mothers who are here. They are part of this conversation. We have people with different conditions. They are part of this conversation. We have manufacturers. They are part of this conversation. We have health workers. They are part of this conversation. And it couldn't have been more inclusive. We have members of parliament here. We have members of the Senate. It couldn't have been more inclusive. We have people online who are following this conversation. I think we are having a conversation of a lifetime as a nation, because health is a very serious matter. Kidinji has, brought us a different perspective as we discuss Kenya beyond 2030. Yes, we will discuss how to manage disease, how to, provide better equipment, better facilities, train better doctors, and all do all that. But he's reminding us that we can do this also much more effectively in preventive and promotive care. It is the reason why my first step was to bring community health promoters on board from day one and to make them part of the health ecosystem in law. So today our community health promoters are part and parcel of our health equation. What KICC is telling us now is, while that is okay, we now need to build capacity for our community health promoters. We are not maximizing what they can do. Yes, they have gone to all the households, but we need to equip them. We need to, build the capacity of community health promoters. We're giving them a stipend today. I think we will have to think seriously about how community health promoters will play that extra role. It cannot be on stipend. It has to be in a different format. So again, this is a beautiful conversation, really. And we also need to move to the space where we control sickness from what we eat. I think that's what KICC is telling us. That is the conversation we must have. And that is why Kenya Beyond 2030 is a healthy conversation for us. We should be able to think health beyond medicine, beyond hospital. So thank you very much, KICC, for bringing that perspective to this conversation. I think we now have some topics for us to discuss as we discuss Kenya Beyond 2030 on matters health. And that is the beauty of this engagement. The fact that we've come here to listen. And I think everybody has had their say, and we have benefited in a very significant way from this interaction. And as a country, we are the richer and the better as we engage in this manner. The reason why we held this summit could not have been any different. I think we've had the outcome that we looked for. We have some homework to carry home, some of us, and everybody else have picked their piece. I want to say to all of you, thank you very much for your participation. I very, very sincerely appreciate everybody who has made this conversation the success that it has become. Asanteni sana.
Ladies and gentlemen, I'm sure you'll agree with me, if commitment was a person, it is His Excellency. Why don't we give him a very, very, very warm clap? 10 hours seated right there is not an easy thing. Your Excellency, you're leading from the front. Let's also appreciate Dr. Mercy Korir, and for your information, she is a medical doctor with a passion to communicate matters medicine. So please, let's give her a clap. Thank you very much, Dr. Mercy Korir. We'll all now be upstanding as we finish this session with the national anthem, the anthem. We'll allow His Excellency to exit, but maybe a quick photo with Dr. Mercy before he exits. And then after that, kindly let's hold our positions as we get ourselves ready to allow...